Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator for today, Ms. Christine Micah, Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead, Ms. Micah.
So hello everyone, and welcome to today's On Call, one of a series dedicated to raising awareness and inspiring action on family presence policies. My name is Christine Micah. I'm an Improvement Lead with the Canadian Foundation for Healthcare Improvement, and I'll be your host today. As I introduce our speakers, please take a moment to introduce yourselves and where you are joining us from using the chat box on the lower right-hand corner of your screen. This webinar is being offered bilingually. I'm pleased to be joined by a team from the Ottawa Hospital, who we are featuring as a case study to highlight their journey toward the adoption of family presence. Deborah Burns is the Chief Nursing Executive and Vice President of Clinical Programs. She is joined by Chris Clement, the Clinical Director of Mental Health, the Academic Family Health Team, and Telemedicine at the Ottawa Hospital. Evelyn Kerr is the Director of Nursing Clinical Practice, who oversees the professional practice for the 4,200 nurses at the Ottawa Hospital. Last, but certainly not least, Susan Smith is a retired nurse who has also been a patient. Susan now enjoys being a hospital volunteer and is a member of the Ottawa Hospital Patient and Family Advisory Council. Thank you all for joining us. During our time together, we want to introduce the concept of family presence and its alignment with quality, both as a policy and practice. We will hear from the Ottawa Hospital about their journey in adopting family presence, which went live in September 2015. They will share some of the evidence and myths, as well as the barriers and opportunities that arose through their journey. Finally, we will share some key levers and winning conditions that have facilitated the transition to family presence and enabled meaningful partnerships between patients, families, and staff. For those who are less familiar with the Foundation, we are a national nonprofit organization funded by the Government of Canada. We accelerate the speed of proven innovations by supporting healthcare organizations to adopt, implement, and measure improvements in patient care, population health, and value for money. Family presence is one innovation at the level of organizational design and service improvement that can have a profound impact on the culture of organizations delivering health services and result in improvements across multiple domains of quality. We fulfill our mission through our focus in 4 core areas through the delivery of programming such as webinars and learning collaboratives, and more on this at the end of our session. At this time, I wanted to take a moment to acknowledge that welcoming families as partners in care looks different in different organizations. While some organizations choose to have an open visitation policy that welcomes families and other visitors 24 hours a day, others choose to create a family presence policy that is specifically for designated partners in care and for whom access to their loved one is unrestricted, while maintaining a separate and more traditional policy for visitors. We encourage hospitals to begin the conversation about what family presence could look like in your organization, and we'll share some potential next steps with you at the end of the presentation. Let's turn our attention to defining family presence. It is both a policy and a practice. As a policy, family presence enables patients, if they so choose, to designate a family member to be with them while they are in hospital. Importantly, family is determined by the patient and may include blood relatives or other support people that are identified by the patient. A second element of family presence policies is that designated partners in care are welcome 24 hours a day, 7 days a week. Finally, the policy might also elucidate how families will be involved in care planning and decision-making. So with this definition in mind, we would like to help organizations consider how welcoming families as partners in care relates to quality. This slide is an illustration of the 6 levers of high-performing health systems based on research funded by the Foundation and conducted by Drs. Ross Baker and Jean-Louis Denis. Adopting family presence must be approached not only as a moral imperative, but as a catalyst for improvement. Family presence policy and practices touch on every one of these levers. There are obvious connections to creating supportive policies, as well as engaging patients and citizens when we're talking about family presence. These policies and practices also serve to promote evidence-informed decision-making and will build your organization's capacity while engaging frontline managers and providers. From organizations who are leading the way in engaging patients and families for quality improvement, they have said that welcoming families was a catalyst for improvement across all levers. Another way to consider the connection to quality is through the relationships between patient and family-centered care, patient engagement, and quality and safety. Patient and family-centered care is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnership among healthcare providers, patients, and families. Family presence is one policy and practice that espouses these core concepts. In welcoming families through the door, further opportunities for partnership will present themselves. Engaging patients and families in quality improvement leads to different ideas and insights than providers working on their own. These partnerships yield fruitful improvements in safety and quality. One concrete example related to welcoming families is the use of whiteboards as a two-way communication tool. When families are welcomed as partners in care, they can communicate valuable information about their loved one that will improve the safety and quality of care delivery. I'd like to spend a bit more time talking about some of the improvements in quality that have been documented in the literature. The Ottawa Hospital will provide a nice overview of some of this literature, and what I'd really like to emphasize is the connection to quality that benefits staff, patients, and families. When family is welcomed as partners in care, evidence suggests improvements, such as improved patient and family experience. When patients aren't isolated from families, and both families and patients can experience less anxiety. There's evidence to support the notion of fewer falls, and families can help convey known risks of falls and help with falls prevention. There are associations with better coordination of care, for example, when families are there as a second set of eyes and ears to listen to discharge instructions. In addition, we've seen fewer medication errors and fewer 30-day readmissions. The suggestion that families be welcome as partners in care is in no way meant to suggest the downgrading of clinical care to families. However, families know the patient best and can be your allies for quality and safety. This table has been adapted from a resource produced by Plaintree and Picker that outlines the ways in which families can be active members in care. For example, designated partners in care can help as communication and education advocates, sharing progress with family and friends, and planning for care and discharge. Families play an important role in communicating the cultural and religious preferences of the patient. They serve as safety advocates, reporting risks and concerns and communicating with staff about known risks of falls. To act as allies for quality and safety, family participation must be welcomed and valued, and there are a number of policies and practices that organizations can take up to create this environment. First and foremost, families cannot be locked out. Families need to be welcomed into the organization, and this begins with family presence policies. Many leading organizations have observed that family presence is a gateway to culture change that results in a number of practice changes to support patient and family-centered care. The right-hand column provides some sample practices to help create this welcoming environment. Welcoming family participation might look like the creation of orientation for families, where families are given an overview of what to expect when their loved one receives care. Another example results in improved communication efforts, such as whiteboards and identification badges, as well as the inclusion of families in transfer of accountability. This list is not meant to be comprehensive, but provides you with an idea of the potential for family presence to serve as a catalyst for improving the culture of patient and family-centered care. At this time, I will now turn it over to the Ottawa Hospital, who will share their ongoing journey to family presence.
Thank you, Christine. This is Deborah Bourne speaking. I'm just going to provide you with a little quick overview of some of the work we're doing on patient experience and how our family presence policy fits in. And then I'll turn it over to my team members who will talk a little more specifically about that journey. But essentially, the Ottawa Hospital has had a vision since 2010 and then renewed in 2014, which is to provide each patient with the world-class care, exceptional service, and compassion that we would want for our loved ones. And there's been a whole variety of initiatives that have happened over the last number of years to get us to that. And we are always looking at sort of what our scores are in terms of patients and families telling us that we are providing them with excellent care. And so during this presentation, I'm going to tell you a little bit about that, around the patient experience structure and how we began the intense focus on family presence. And then my colleagues will talk a little bit about the environmental scan we did, how we implemented the policy, the communication plan that went with it. And then we also have a patient family representative here to talk a little bit about that, and she's been part of our journey throughout this whole last few months. And we are in the middle of doing an evaluation. As Christine said, we did implement the policy on September 14th, 2015, actually, and we've been doing evaluation ever since. And I think going forward, we will make some, adjustments just to make it even better. But overall, it's been a positive experience, and we'll talk about some of the lessons that we have learned. So we're just going to change to the next slide. And this is really a picture of the structure that we have in place right now that is driving our focus on patient experience here at the Ottawa Hospital. And we've done a variety of things, but in sort of, I guess, winter and spring 2015, we realized that we needed to put a renewed focus and push on what we were all doing and how we were all engaging in creating a positive patient experience here at the Ottawa Hospital. And it really is an interprofessional responsibility. And so what we did was we created our first patient and family experience steering committee. And Dr. Jeff Turnbull, who's our chief of staff, and myself co-lead that group. And we have our patient and family advisory committee, our Ottawa Hospital-wide one that is both on it and connected to the steering committee. And you can see that we also connect through a dotted line to our Quality and Performance Council. And then Chris, Clement, and Evelyn Kerr, who you will hear from in a few minutes, are really the project leaders. And we've created a series of working groups that have allowed us to focus on some particular areas we knew we needed to do better on in order to continue to provide excellence in patient experience. So, for example, we have our Patient Experience Acceleration Working Group, and we really use that group to drive initiatives aimed at helping some of the units with challenges, providing an excellent patient experience, to be able to work on that and improve things on their unit. And we have many tried and true kind of tactics that we use, and plus things that they realize as a team that they could do to be better at what they're doing. Our integration working group is really about taking the tactics, things like bedside shift reports, hourly rounding by nurses, nurse leader rounding every day, care boards at the bedside, and making sure that we keep on those because we have evidence to show that they have actually improved a lot of our outcomes for patients, things like reduced number of falls since they were implemented, better communication, less pressure ulcers, reduced delirium, and overall better perception of communication with the nurses. We also have a communication working group because what we also have realized over the years is that a lot of how patients say and perceive that they experience care in the hospital as excellent is determined by how the professionals and non-professionals in the organization communicate with them in a way that they seek to understand who they are, what their preferences are, what they want to have happen, and act on it. We're adding a new group this year because we are doing fairly well with our patient engagement, and we have patients on many committees who are active contributors, and you'll hear from one of them today, as I said, but we're going to actually look more into what are some of the best practices out there and perhaps create some of our own and do even better than that in the coming year. So the Family Presence Working Group is the one we're going to focus on, and it really, and so I'll talk about a little bit more about, or you'll hear about the work of that group in a few minutes. But if you go to the next slide, and we just did that, The focus for this year for all of the groups has really been around, creating a foundational communication curriculum, and we've done some very large engagement processes to involve patients and staff and physicians in this. And the acceleration initiatives have done a whole bunch of things, but they've focused on sort of patient communication and handbooks and follow-up calls once they leave the units to ensure that they got what they needed and weren't left out there hanging. And we've also used our integration group to conduct focus groups with patients and families to help us understand what quality improvement initiatives need to happen on units. Clinical Tactics 2.0 is really about what I talked about earlier, ensuring that the units are doing the things that we know work, like the hourly rounding, the bedside shift report, the care boards at the bedside, and others. And although, those of us who've worked in hospitals for a long time know that nurse-physician rounding used to be something that happened all the time, it actually happens less often than it used to. We've been reinstituting that on some units with some really wonderful results because they do it with the patient. It's creating much better teamwork and collaboration, and it's something that we're having to work quite hard to get off the ground again. So I'm just going to finish this part by saying that our journey for around the family presence policy, I think the organization has been talking about changing its visiting policy for a number of years because we had a policy that said 3 p.m. to 8 p.m. only, but really hadn't gotten to doing it. And so in February 2015, we decided that by June 1st, we were going to implement a new policy and have completely open visiting hours. And what you'll hear from our team is that what ensued was a flurry of activity that began at the beginning of March to make it happen. So I'm going to turn it over to Evelyn now, and she'll lead you through the next couple of slides.
Okay, so thank you, Deborah. The next slide addresses what we did from an environmental scan, and we had an opportunity with Chris and I co-chairing the Family Presence Committee to really look to see what currently existed. We had a corporate policy that had not been updated since 2004. We had discussions with our patient advocacy department, and from their survey of patients, they really wanted a change with respect to the time frame of 3 to 8 in the afternoon. We also did a review of the literature to really see what the benefits were for patients and families around more open visiting. And I've got some information here that I'll run through very quickly with you, just about some of the myths that are out there and some of the absolute benefits that we can see from the evidence. The other piece that we did, we contacted Kingston General Hospital, and it was really great to have the opportunity to dialogue with those individuals at that hospital who had implemented family presence policy in 2009, and to learn from them their experiences, the challenges that they had had, how things had changed from 2009 to current state in 2015. The literature itself really is predominantly focused in critical care environments, to tell you the honest truth about what you see out there. There's been numerous articles written in critical care units and intensive care units in particular. And in that first slide that we have, for example, by Berti et al., this was with 531 intensive care units in Europe, where they discovered that, in fact, open, unrestricted visiting hours actually help to decrease the heart rate in patients. We also had another study, Davidson. That's a really interesting study if anyone wants to look more deeply into it. It really does talk about the notions of fact or fiction, and really looking at some of the concerns that were raised, that there might be a risk of infection, that there may be negative physiological effects on heart rate or blood pressure, patients feeling more stressed, families needing to rest more, and the need for access to information. And really what what came from this particular study was that there really was no evidence, and in fact, the opposite could be found. There was no increased risk of infection, and physiologically, there were improvements to the patient's condition. I'm not going to go through all of these because of time, but I think it's important to reiterate a piece of what Christine has already mentioned with respect to the literature. It's that what we can see is that patients actually have less anxiety, less confusion, less agitation, heart rates go down, blood pressures improve, the length of stay improves, it's shortened in the intensive care unit, patients feel safe, they feel secure, families feel more satisfied with the care that their loved ones are receiving. So it really is a picture of something that as a group we knew we wanted to embark on with respect to a journey. So I'm going to pass it over to my colleague Chris Clement.
Thank you, Evelyn. So as Deborah has alluded to, we actually had pretty tight timelines when we embarked on this journey. We started in March and we were aiming for June 1st. So what did we have to have in place actually to make that happen in those fairly tight timelines? Well, the first thing we really needed was clear direction from our senior leadership. And I think you can see, given the illustration of the structure, we certainly did have that mandate that this was something that the Ottawa Hospital really believed would lead us in the right direction and improve the patient experience. The next thing we did was around creating a vision and assessing the degree of change for the organization. What we found when we started to meet with our working group actually, that there were large pockets in the organization for whom this actually wasn't a change. So when we looked at it, we had thought it would be this major change, but in truth it wasn't. We were actually going to be providing people with the policy that backed what they had been doing in practice for a long period of time. We also wanted to ensure that we had the right stakeholders, and I'm going to share with you the diversity of our working group in just a couple of moments. We wanted to clearly define our roles and responsibilities so that everybody knew not only what we would be doing with respect to this working group, but what we would be doing with respect to implementing this policy. Through our working group and involving the right stakeholders, we were aiming to create champions who would be accountable for ensuring that the policy was rolling out as we intended. And the last piece that was part of our recipe for success was really around communicating often and communicating broadly. I'm going to share a little bit more about our communication plan in a couple of slides. So moving along to the implementation process, the first thing we did was develop a committee that had a variety of key stakeholders. We needed to ensure that our members were fully engaged and that we had everybody assigned something to do. And how we did that actually was we looked at what needed to be done, policy development, development of the tools in the toolkit, around signage. So we created subgroups. So everybody was actually working on a piece of the subgroup and coming in reporting back to that committee. We wanted to ensure that we had patient representation. We were, after all, doing this to improve the patient experience, so we actually were fortunate enough to have a couple of people come and participate as patients, and we're going to hear from Susan in just a few moments. We had a plan. We established our timelines, and again, they were fairly aggressive timelines, and we focused on our communication plan. So I'll just share that with you in a moment. The diversity of the membership of our working group. We had members from patient advocacy. We had members from our security department. We had members from medical affairs, ensuring that the partners were going to be, the physicians were going to be partners with us in rolling this out. And then we had a broad cross-representation from across the organization. So we had interprofessionals, so we had the chief of our occupational therapy, of our dietetics. We had clinical managers who were going to live this on a day-to-day basis. We actually had frontline clinical nurses, and again, we had patient representatives. So a very broad, diverse group of people that made up the membership of this committee. Another key success for us was our communication plan. We worked quite closely with our communications department here. We identified our target audiences, and we had a number of target audiences as we looked at this. We were not only aiming to communicate with our own staff, but we were going to also be communicating with the public. We developed key messages for both of those groups. And then we sent those key messages out to the managers and to the staff. So we had a fairly elaborate way of putting together a toolkit and sharing that amongst our team here. We revised our key messages on our website. We presented to a variety of different stakeholders within the organization, our senior management team, our nursing managers, our educators. We used our internal communication avenues such as our journal to put articles in there. And then we were holding a nursing skills fair, so we actually put together a really nice poster presentation on the family presence policy and broadcast it at the nursing skills fair, where it got a lot of really good input and interest from the frontline nurses. We had a couple of things that were key deliverables. First of all, we needed to have our policy developed and approved, and we didn't start from scratch there. As Evelyn said, we were fortunate to be able to work quite closely with Kingston, who shared with us their policy. So we took that and had a subgroup of our overall working group pull that together, had that approved by our senior management team. And then to ensure we had good and effective communication with our staff and with our patients, we developed frequently asked questions for our staff, frequently asked questions for our patients. And then Evelyn and the Nursing Professional Practice Department put together some scripts for nursing. So we anticipated what some of the potential scenarios might be and how we wanted people to be able to respond. And so we had those scripts available for nursing. And the next slide is really just a look at some of the resources that we actually developed, so a pictorial of those resources. So again, some of the articles and the FAQs and the policy. I'm going to turn it over to Susan to tell us about her perspective on the journey.
Thank you, Chris. Hello, everyone. I joined this working group a few weeks after it had initially started or had initially met, and I was very happy to join them. As I think any of us can imagine, having flexible visiting hours, being able to be with our loved ones, or if we're the person in the bed, that our loved ones are with us. And it doesn't mean that it's open house, of course. It doesn't mean that everybody come and have a big family reunion at the bedside. But it is to be respectful on both sides and to work out how this is going to work. But the importance of being there, having your family members there, I can't stress enough. When both my parents were coming to the end of their lives and I was able to be there with them, and if I wasn't there, one of my brothers was just so important, and I'm sure many of you can relate to that as well. And it also helped me after their death that I was there, that I was present, that I knew exactly what had happened to them and was part of that whole process. I also just want to tell you that this working group was quite, to me, very amazing, so professional. I hope I'm not embarrassing anybody. But the leadership, first of all, they did obviously have leadership from the top, strong leadership and direction. But these two people who led this group and all of the people who came to the table were certainly dedicated and committed and made this happen. And while it was delayed a little bit because some things came up along the way that weren't expected, but it was worked through, and it was always worked through from what I could see and hear in a very professional manner. It was going to be done, it was just delayed. It wasn't ever a doubt that it would happen, and I believe it's happened in a really good way. So I encourage all of you out there to really look at this seriously and to make it part of your community at the hospitals.
Thanks, Susan. So we have a little pictorial. This was our, basically our little motto, the little engine that could, because we were meeting so regularly and so quickly. We thought we could, and in fact, we had a little blip along the way. June 1st was supposed to be the actual implementation date, but as everyone has already addressed, we actually went live September 14th, 2015. And so if any path to success, we always think that it's a stepwise process and that it's going to all go according to plan. But in fact, the path to success for us was a little bit more convoluted, and I guess that's just a part of, for everyone out there listening in, what you feel is going to happen. Sometimes there's unexpected events occur, and so just to be prepared that some things can happen. And so that's really what we wanted to share with you, is just some of the challenges that we had. And I'd have to say that there certainly were concerns about having more open visitation after 2,200 hours at night. Just concerns about who was going to be in the hospital, knowing that the overall number of staff in the facility obviously is reduced in the off hours. So wanting to know what could we do from a security perspective. And we had the opportunity to have discussion with our VP of Human Resources who also had responsibility for security, and we had reduced access to the hospital through two main entrances at the two main campuses and have security in place from 2200 to 6 o'clock in the morning. The other challenge has to do with questions and hesitancy from nurses, and that we were prepared for based on what we'd read in numerous articles, is that certainly the challenge for open visiting in the off hours in particular is raised by nursing staff. And we were no different here. And part of the preparing scripts was really helping nurses to feel more comfortable in having conversations with family members who were having concerns about leaving or being able to understand more with them what their concerns were and with their loved ones. And really what we've been tackling, and as we move forward, and part of our evaluation is really balancing the needs of the family to visit with the needs for the patient to be able to rest and recover. And so we're working through some of those challenges. We have been, as Deborah alluded to, looking at evaluation, and we had set out right from the beginning with our timeline was looking at how would we evaluate effectiveness of the family presence policy. And so we have clinical administrators on site who are here in the off hours. And between Chris and I, we've been collecting any information that comes into them, stories that they share about concerns that may be raised with patients, families, with staff around concerns in the off hours. And I have to say those numbers are really, really low. The issues that have been presented to us are issues that were presented to them even before we implemented the 24/7 open visiting. The other, we've been following up with our patient advocacy group, and to date, I believe, and this is 6 months later, we've had maybe 2 concerns raised, and it was to do with noise at night, with visitors in the next bed. Patients and family comments, we were looking for feedback. We've received positive feedback around more access to loved ones. We've also heard some information around, again, noise at night. And so we've been looking at and reviewing exactly what and when does this happen. Is there a particular area where this is happening? Because it helps to inform us on what our follow-up plans will be. We're also through discharge phone calls that are done, looking at any concerns there, and again, it certainly points to noise. And from a security perspective, there really has not been any major concern raised with us. So if we go to the next steps, we are following up with any units that we have heard that there were any complaints that have come through the patient advocacy group. We are continuing to educate and support nurses. We actually have a shared governance, a unit council for nurses that represent a unit across, each unit across the hospital. There's about 50 nurses in that committee, and we presented to them, heard their feedback about concerns that they were, if they had any concerns, an opportunity for them to dialogue with us and to share some go-forward plans with them. We're looking at our website. We've already tweaked the website and the web message. We're looking at, I think, more with what Christine mentioned earlier around family participation in care, and really looking at how can you help as a family member for the opportunity for your loved one to get the rest that's needed and to be part of the plan of care, which was part of what was in our original intent with our frequently asked questions. But in listening and hearing the feedback, we know we need to give that perhaps more of a stronger voice around how do we engage nurses with families around the plan. We're looking at promoting quiet time at night. So knowing that everyone after 2100 hours, it is a time for quiet, for rest and sleep. The last lessons learned for those of you embarking on a journey such as ours is we really can't emphasize how important it is to have buy-in from senior management. Right from the get-go, we knew that our senior management team really wanted to have this change. It was very important for us to know that in our committee that the patient voice was there, and having patient representation on our committee was very, very helpful. We can't stress enough the importance of communicate, communicate, communicate. Although we thought that we had sent out numerous messages, we knew that every forum, every opportunity we had to share our experiences or to hear or listen for feedback, we took that opportunity to do that. It's important to have a great team working. As we alluded to the fact, we met every 2 weeks, and as Chris Clement has indicated, we really had a wonderful team that were very engaged and very accountable for the work that we had tasked everyone to do. And always anticipate the unanticipated, and that's certainly what we discovered with our deadline of June the 1st. Perhaps we needed to look more carefully around the security issue, and so we certainly did not anticipate that to start with, and let common sense prevail. And I think that that is one of the things is people will talk about a one-off situation, a very extraordinary situation that may have happened, would have happened no matter what, whether we had a family presence policy that was 24/7 or not. And I think that the final point is that family presence truly is a balancing act. It's really knowing that we are considering the care needs of our patients, all of them, our recovery needs of all of our patients, and knowing that we're all here to ensure that they get home safely and with all the supports in place. Thank you.
So I think we have some time for questions. I'm not sure, Christine, if you're going to moderate that.
Hi, it is Christine, and I will be moderating. We do have a question period and have allotted a few minutes before we move on to talk about future opportunities related to family presence. There have been a few that have come in on the chat. One question from R. Edwards talking about how MD heads have rejected family presence. So can you talk a little bit about how opposition was handled in your case as you moved to family presence?
So I think we're all looking at each other because we're sitting in the same room, and honestly, we did not get opposition from our physician partners, and in fact, they were completely engaged all along. Our biggest questions and I guess challenging came from the nursing group, which is understandable because they're really the ones who were there at the face of it, you know, all night long. So we didn't have that experience, but I think probably with any group that provides opposition, it's around understanding what it is that they're concerned about, helping to put in place things that address it or to give them tools to address the challenges when they come up. And, you know, as Evelyn said, in the beginning, people had a lot of, well, what if everybody decides visiting at 2 o'clock in the afternoon isn't good anymore, and they're going to visit at 2 o'clock in the morning just because they can. And people raised a lot of those kinds of things, again, primarily our nurses, and honestly, it doesn't happen, but it was still important for us to hear all of those things along the way. And then also, I think part of my role was senior management was extremely supportive, and in fact, it came right from the CEO that this needed to happen and we wanted it to happen. But I always remind them that these one-offs are going to come up, and when they do, it might have everything and nothing to do with our new family presence policy, because we weren't looking for feedback on what was happening in the middle of the night before, but it was happening. Because if you go back and read the reports from our overnight supervisory team, challenges came up all along the way. So I guess just listening, addressing as best you can, and agreeing. And one of the things we did do is agree to put a very robust evaluation process in place so that we would hear concerns as they arose.
Thanks, Deborah. And good segue to one of the other questions related to specific metrics around patient experience. And of course, it'll never be a direct correlation, but can you talk a little bit about perhaps anticipated improvements in patient experience, or if that's something that you have your eye on, given that you're already measuring? Can you talk a bit about that?
So I'll start and then I'll let the others chime in, but certainly it is patients having access to their family members it has been shown in the literature and in the studies that Evelyn reviewed, to improve patient experience for sure. We are always looking at what our patient experience scores are, and like most hospitals in the province, or probably all, we use the PICR Patient Satisfaction Survey tool. And what we know is that there's 5 sets of questions, 5 dimensions on that tool that have the most impact on what patients perceive as their experience at the hospital. And one of them is family presence and family involvement in care is one of our top 5. The other ones are accessibility of doctors and nurses, pain control, and a variety. But that for sure sits in the top 5 most important ways to influence patient experience. And so that was one of the drivers for us to do this, in addition to knowing that it's just the right thing to do. So I think that's it.
Thanks. That's great, Deborah. And there was a question, and perhaps I posed to you again, related to the integration of sort of family presence and welcoming families as partners in care, and the integration into the plan of care. And from that, I'm interpreting, and I hope correctly, related to some other known presences that welcome the participation of families, such as at shift change or in daily rounds. And I think it was Evelyn who mentioned it briefly in terms of next steps. But did you have anything else to add in terms of how family presence has changed practice, or looking ahead, do you anticipate that this will sort of influence other practices?
So, yes, it's Evelyn. From our perspective, implementing the policy was basically, I would say, phase 1, and the evaluation as we've gone on. We knew that the policy itself would probably be changing and evolving as we moved forward. And that's really the lessons that we've learned with respect to being clear in the messaging, to ensure that the plan of care right from the get-go, from the moment of admission, includes a discussion between the patient, the family member, and the care team. Particularly, we know that if the nurse is going to be there 24/7, having an opportunity to really find out about the wishes of the patient and family around who is going to be participating in that care, who is the key contact person, having an opportunity to really include the patient and family in the decisions that are being made about that plan of care. So really having more of an opportunity to share this message, reinforce this message, is what we need to do here at our hospital to ensure that we haven't lost sight of that piece, because that is really an essential ingredient.
And we do have, as Evelyn said, we have a ways to go, and I think that will also help with identifying who the patient and family want to be there with access 24/7, because not necessarily everyone. That's one of our lessons learned. But certainly when we talked about the bedside shift report and the rounding, we encourage, and hopefully it is happening in most places, I'm not going to say 100%, that if the family member is there and the patient wants them to participate in that exchange, it certainly is helpful, just because it's another set of eyes and ears to be hearing about what is happening. And we've heard family members say that it is very helpful. I'm not going to tell you that we know what's happening with every patient every time, but certainly it's something we're working on as part of all this.
One of the things we can tell you from a metrics perspective is that those units that are clinical units that have really embedded the bedside shift report, the hourly rounding, and the use of the care boards, we do a prevalence where we're actually doing an audit twice a year, and we can see real correlation between the prevalence scores and reduction in falls, better pain management, inclusion of the patient and family in the decisions that are being taken. So we can see that does take place, and it does result in overall scores that are better for care from a quality perspective.
Well, thanks very much. It's Christine again, and at this point I think we will move on. Now there are a couple other questions that hopefully we'll have time at the end of the session, so I'll just hold those. And if not, certainly we can circulate those questions along with responses in a post-webinar email. And there were certainly requests for documentation related to FAQs, as well as the nursing script. So we will try and compile these materials and disseminate out following the webinar. I hope after hearing the Ottawa Hospital story that this has provided you with some ideas about the opportunity within your organization. CFHI is the lead organization on the Better Together campaign, a campaign launched by the Institute for Patient and Family-Centered Care, which aims to change the concept of visitors to partners in care. We know that many organizations across Canada have identified patient and family-centered care as an organizational priority. However, operationalizing this philosophy is not always straightforward. Adopting family presence policies in practices is an innovation at the organizational level that espouses this philosophy. In preparation for the launch of the campaign, CFHI undertook a survey to better understand the state of visiting hours in Canadian hospitals. Of the 114 hospitals surveyed between February and April 2015, only 30% of hospitals have accommodating visiting hours posted on their website. In spring 2015, we conducted market research to better understand the attitudes and beliefs of both the general public and the healthcare sector. We polled 672 health sector professionals and over 1,000 members of the general public. In both instances, respondents supported family presence policies, overwhelmingly so. There's a tremendous opportunity to better meet the needs of patients, families, and staff by adopting family presence, and we're calling on Canadian hospitals to join the Better Together campaign. As the Canadian lead on this campaign, we are providing a suite of offerings to raise awareness about the campaign and support organizations in adopting this change. In November, we released our baseline study of the 114 hospitals, and at the same time, we've launched a change package for organizations considering making this change. The change package offers a flexible stepwise approach grounded in the principles of patient and family-centered care and incorporates quality improvement and change management methods to move toward a family presence policy and practices in your organization. This change package is divided into 3 phases and focuses on 5 core action areas that organizations will consider as they adopt and implement family presence. In addition, we have translated a number of the IPSCC resources, and these reside on our website and within the change package. In addition to webinars, such as the one we're on today, we're also developing case studies of organizations undertaking this change. I'm also pleased to announce that the Foundation will be launching a new e-collaborative in early March. This collaborative is aimed at Canadian inpatient hospitals who would like to adopt a family presence policy and associated practices. The collaborative will be virtual in nature, and a number of tools and supports to accelerate the change and build a network of change champions committed to patient and family-centered care. We will be sharing news on our website, newsletter, and social media in the coming weeks about how organizations can participate. You don't need to wait until March to pledge. As one concrete step toward creating a culture of patient and family-centered care, we invite you to pledge to the Better Together campaign. This is available now on our website, and the pledge is designed as a 3-phase commitment that mirrors the change package. To date, 11 organizations have committed to at least one phase of the pledge, and we would invite you to join them. We've come to the end of our time together today, and at this time I would invite questions and comments from participants. Please submit your questions or comments using the chat box on the bottom right of your screen. And perhaps to start us off, I'll go back to those original questions. I see one from Linda asking about how did you handle worry about increased workload on nurses by increased family presence? So over to you, members of the Ottawa Hospital, to answer that one.
So it's Deborah. This was actually raised by our nursing union primarily, and we did have a bit of a talk about it, but I mean the reality is there's still not a whole lot of visitors at night, really many more than there were before. They were concerned that there would be a lot of people around and they wouldn't be able to get their work done because there would be too many people in the room. And really, this really came back to the scripts and the things that we worked with we needed to work with the nurses on in terms of if they did have to do care, that it was okay to ask family members to step out for a while, or in some cases if a patient wanted them to stay, to be there. And they could still have the same kind of conversations they were having with patients during the day, just because it was 10:01 instead of 10 o'clock. And really I think it's they were worried that they would have to spend a lot of time, I guess, worrying about who was coming in and out and that there would be too many people. But it hasn't happened, and we talked to them about that we would review it if it did happen. And I think it was more of a concern about what if rather than what actually happened. And so far, it hasn't come up as an issue going along. But really giving them the tools to have the conversations about, could you give us a chance? We need to do these things, and that's okay to let the family and the visitors know that some care items had to happen.
Next question that I have for you is from MJ Trepanier. Can you say a bit more about wellness calls? Is this done for patients on all units and specialties?
So the discharge calls are a number of units. Not all the units are represented, but the expectation is that within a week of discharge, there is a phone call back to find out how they're managing. Is there any particular problem or concern that the patient has? So it's troubleshooting any concerns that they may have raised, and then the person taking the call moves that concern back to the unit from which they were discharged, and the manager or nurse, we have what's called a CCL position, clinical care leader. They would do a return phone call with respect to follow-up. What's also interesting is that as part of our patient experience structure, we have acceleration groups who are looking at ways or strategies in which they can improve their overall patient experience scores, the satisfaction scores. And some of those units are actually implementing a phone call within 24 hours of discharge, just as a courtesy call to make sure is there anything that you're concerned about, any follow-up with the physician that you are thinking about, medications that may need to be reinforced, any pain that might be of a concern. Those kinds of follow-up questions are being answered and provided.
Thanks very much. And I think we have time for one more, and I'm going to pull out one from Jackie, and I'm pulling it out because it's a very common question that we've received and are still sort of working on. And she's asking, can the Ottawa Hospital share how the family presence was handled within their mental health program? Were patients involved? Was there any particulars that those of us in mental health facilities can learn about. So I'll pose that back to you. Is there anything specific related to family presence in cases where we're talking about mental health? Over to you.
So thanks very much for that question. This is Chris, and I actually am the clinical director for the mental health program here at the Ottawa Hospital. And there were no exceptions to the policy. It was implemented broadly across the organization. And the same kind of conversations that Evelyn talked about having with patients and with families, we expect people to have in mental health as well. In other words, does this fit into your plan of care? Is it appropriate? And is it in your best interest to have those visitors at those times? So the same guiding principles that apply across the rest of the organization actually apply in mental health as well, and we have the same policy.
Thanks very much. That's great. And I'm grateful. There's so many great comments and questions coming in. I did want to proceed with the presentation just in terms of wrap up, but know that these are all questions that we'll take away and hope to get some responses to you in a post-webinar call. So thanks so much for your great participation. We did want to alert all participants to some of our upcoming webinars related to Indigenous health. This is part of CFHI's recommended learning journey on Indigenous health, and these of course remain open access and free to participants. So please join us in March and early April for these events. You'll find out more shortly on our website. So thank you all for your participation, and a special thank you to the Ottawa Hospital. As you leave the webinar, please take the time to complete this 5-question evaluation survey that pops up on your screen. This is essential in terms of our feedback to us and how we can make our offerings more relevant and applicable to you and your care settings. So thank you very much for everyone who's joined the call, and again, thank you to the Ottawa Hospital. You will be seeing something in your inboxes from us related to resources discussed. And thank you and have a great day.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.